want to just kind of stress why I love doing full arch restorations. And the reason it is because I have complete control of the anatomy of the smile. I don't know, is there a couple prosthodontists in the audience today? Okay. So prosthodontists, we kind of have a reputation of being a little obsessive compulsive. And I mean, I do plenty of crown and bridge cases in my office, and they come out great and the patients like them. But sometimes, you know, you have gingival recession, just different things that with your fixed cases, you wish the final aesthetics could be better, but you don't have complete control over that. When you're doing removable type of prostheses or full arch prostheses, we control everything about the smile. So we control the midline, we control the smile curve, we can control the papilla curve, the buccal corridor, the incisal edge position, the tooth proportions, the plane of occlusion, and the tooth contours. So, you know, as a prosthodontist and as someone who likes to set my own teeth for dentures, I really enjoy developing a patient's smile. And the way that you learn how to do this is through removable prosthodontics, basic prosthodontic principles. A funny short story is when I finished dental school at Ohio State, I absolutely hated doing dentures. I was terrible at it. I just, my outcomes on the patients I had done, you know, just adjustment after adjustment. And so I really did not learn how to do dentures when I was in dental school. But when I went to my residency, my pros residency, the first day I got there, I went to my instructor and said, I hate doing dentures, give me all the crown and bridge, give everybody else those removable cases. And he kind of laughed at me and he put his arm around me and said, son, for the first 3 months, all you're gonna do is removable prosthodontics. And this was a gentleman who was a prosthodontist in California and Hollywood, and he did like all the dentures on all the movie star patients. So he was really good at developing natural contours. He was an expert at like tinting the dentures. It was really a good experience. And I really did learn that learning to set teeth, learning how to change the directions of teeth or overlap teeth is really how you learn the art of the smile, and this then can translate into your crown and bridge and to your full arch dentistry. Christian Coachman, who's probably the most entertaining lecturer I've ever seen speak, had a quote that the best smile designers are the dentists who understand the basic principles of prosthodontics and have mastered the art of denture fabrication. So if you want to do a lot of full arch dentistry, I would encourage you to review your basic prosthodontist, take some courses, because it's much more interesting as a dentist than it was as a dental student. And it really has become a lost art. There's not as many dental technician schools for teaching dentists how to, how to fabricate dentures, how to set teeth, how to carve natural anatomy in the pink, and I think probably, correct me if I'm wrong, Alan or BJ if he's still here. I mean, a lot of the technicians are kind of trained in the laboratory. Am I right?
Every technician that does our setup for full arch,
Mm-hmm.
but if it's going to be a zirconia in 6 months, anybody who does full arch for us is a denture technician.
Beautiful.
And then we give them a mouse, and now they do it digitally.
Yeah. But I don't think that's uniform throughout the country. I think that's,
Probably not.
yep, so. Okay, so a denture can look beautiful. It can be indistinguishable to someone who's talking to you if you know how to do it correctly. But it really helps to know these principles when you're doing full arch types of cases, because you can really make these cases look natural. And before we delve into the nuts and bolts of LOCATOR Fixed, I just wanted to kind of distinguish between what I see two ends of the spectrum in terms of philosophy of care. I look at one end of the spectrum as tooth carpentry, and I look at the other end as comprehensive care. And what I call tooth carpentry is the dentist who is just a drill and fill dentist, does not do a comprehensive exam, does not look at the big picture, just wait for the patient to need a filling, and then they place a filling, and then they break a cusp, and then they need an endo procedure, and then they need a crown, and then the crown goes bad, and they take the tooth out and place an implant. And so they're just reacting to problems instead of looking at the big picture so that the patient could have a good long-term oral health. This patient came to me, and this picture here was after I did some occlusal adjustment, because when she came to me, the only tooth in her mouth that was hitting was this molar right here. She had a big anterior open bite. And she told me that for the past 15 to 20 years, that's what she had, this one tooth at a time, nothing correlating to anything. And she had a little booklet. It had all her receipts. She spent $150,000 on her mouth, and this is what she had to show for it. This is an extreme example of what I talked about of why I like doing full arch dentistry and how we can control gingival levels and tooth proportions and all that kind of stuff. But in order, and you can see the bottom picture, she had exactly the same thing in the lower, like eight or so implants in the lower. And the only way that I could think to treat this patient was to cut all her crown and bridge off, take fixture level impressions, proceed like I'm making a denture with base plates, wax rims, mounting the case, setting teeth, so I could see where her teeth should go. And so we did this in both arches. And before I go to the next slide, you can see this is one of the first full arch cases I ever did. And if you think about, if I could have gotten to this lady a little bit earlier in her dental life, and I could have, found things that led me to believe that she wasn't going to be able to maintain her teeth throughout her life, and we could have made her something like this, she would have spent a lot less money, and she would have had a lot better outcome. So what I did was I took impressions, fabricated master models, took her abutments from the crown that were holding her crowns, put them on the model, and did a setup around them. And then what I did was place the, let's see, let me go back. Placed a little putty matrix around these to see where the teeth were in line with where the implants were, and then evaluated the health of each of these implants. In the end, she had peri-implantitis on most of these implants. Some of the implants were going in directions that were not compatible with a screw-retained type of a prosthesis. And so we ended up taking out the majority of these implants. There was like 2 or 3 implants left when all was said and done. And we ended up doing screw-retained full arch types of restorations, top and bottom. Saved a couple of the original implants. And then here's the prosthesis that was made here at Rowe, upper and lower, full arch zirconia, screw retain. Just a little closer up picture. And here's our patient after her rehabilitation. And just a little video. So Sam's the head of the full arch department here in this building. And if you ask for one of Rowe's booklets on full arch, she's going to be one of the patients highlighted in that. And I would suggest that you do get some of these full arch booklets, a bespoke booklet, because it'll show you really some impressive work and really give you some good thoughts in terms of what you can accomplish, for these types of patients. So there's her before and after. All right, so let's get into LOCATOR Fixed. So locator fixed is an existing validated technology with a new application. And so let's first talk about the different options for edentulous patients. Because how I want you to look at locator fixed is another tool in the toolbox. For full arch patients, you can do snap-on dentures, you can do screw-retained hybrids, you can do bar-retained snap-on types of dentures. There's a lot of different options, a lot of different materials. And I don't think that we as dentists should just have one choice that everybody gets. I think we need to look at each patient, look at their needs, look at their biology, and by doing that, we can really have a specific custom plan for that patient. So these types of patients can either be previously dentulous, or they can have a hopeless dentition. And another thing that I've been seeing more and more is patients that have existing implants or overdentures that we then convert to a full arch type of a restoration. Sometimes we have to remove implants to do that. Sometimes we can use the existing implants. And that's why the case workup is so important, because when you're doing these cases, restorative space is the most important thing. If you don't have enough space for the materials, you're going to get failure. So to work up these cases, we need to know where the teeth are going to be and where the existing implants are. And from that, we can determine if we can keep that implant or whether we need to take that implant out and place a different implant. So the first option would be a ProArch on 4. So ProArch is Straumann's term for a hybrid type of restoration, but there's plenty of other all-on-X or teeth in a day, or all the different names that we have for these types of restorations. And this type of restoration was invented to try to keep us from doing significant bone grafting, from grafting sinuses, from doing block grafts in the mandible. And so this philosophy is placing 4 implants either between the mental foramen or in between the sinuses, and tilting the distal implants so we can increase the AP spread, decrease the cantilevers, and take some of the stress off of those implants. And by doing that, we can add more teeth and give the patient a longer arch. The next option would be a ProArch or a hybrid all-on 6. And with this, there's been a lot of studies on short implants, and the studies clearly show that short implants, when done properly, have just as high a success rate as the longer types of implants. And so now we can eliminate those cantilevers even more, and we can extend the arches even fuller. But when you're doing this and you're dealing with this anatomical structures, that's when it really becomes important to do guided surgery. I have surgeons I work with that love to do freehand, and some of them are very good. But in general, the outcomes that I see for these types of cases are always better when it's guided, because we're doing the surgery virtually. We're not walking into the surgery with any surprises whatsoever, and so the workflow just becomes seamless, and we have really great outcomes with guided surgery. The removable options are 2 implant or 4 implant snap-on types of dentures. It can be Locator, it could be Novaloc from Straumann. And another option would be mini implants. I don't do a lot of these types of implants, but there are indications. There are some patients who have very thin ridges and they don't want to, or medically they can't undergo significant grafting procedures to be able to use standard size implants. So this is certainly another option. And then for the severely resorbed maxilla, zygomatic implants are another option. And now we come to locator fixed. So like I said, it's an existing technology with a new application. The abutments are exactly the same. There's no different ordering that you have to do. The only difference is that the housings that hold the inserts are redesigned so that they're stronger, so those housings aren't going to pull out, with patient function. And then the inserts are a much stronger material, and these are made of PEEK. Am I correct, Colleen?
Yes.
Okay, so they're made of PEEK. So it's just a very, much more rigid insert that allows you to create a fixed prosthesis. It's flangeless like a screw-retained prosthesis, but there's no screw holes coming out the top. And the advantage of that is, when we see these full arch cases break, it's usually where a metal cylinder is or where the screw hole is, because the material becomes thinner. So with LOCATOR Fixed, you don't have that screw hole. It's very smooth to the patient's tongue. Again, just another tool for you to use, another option for our patients. And this just highlights what I just said a little bit more. That could be me. Oh, shoot. Sorry, guys. Okay. Okay. I went forward.
Dr. Dean, I'll text him and tell him you're in a meeting.
Okay, I appreciate it. Okay, so the abutments are exactly the same. The processing inserts that you pick up the attachments with are the same, and the techniques, if you're doing an intraoral technique, are the same, using chairside acrylic or another acrylic that's a self-setting acrylic. The difference is in the housings are different, the inserts are different, and the removables have a flange and have a convex intaglio surface. LOCATOR Fixed has a flat intaglio so that it's cleansable, just like all the other screw-retained types of restorations. One of the advantages of LOCATOR Fixed is, I've heard dentists say that I just can't remove all that bone just so that we could put implants in and have some type of a fixed restoration, because they feel that if something goes wrong and we flatten the patient's arch out and now they can't have an implant restoration, we've kind of made them a dental cripple, because it's going to be very difficult to wear a denture. So with LOCATOR Fixed, we don't need as much restorative space. So in planning the case, the surgeon can do less bone reduction. Because the typical all-on-X type of patient needs from 12 to 16 millimeters of space, depending on the materials that we use, while a LOCATOR Fixed is usually an 8 to 12 millimeter space, again, depending on the restorative material that we use. Existing cases that are in a snap-on type of a denture that have locators, for instance, that you want to convert to a fixed prosthesis, many times one of the biggest problems I see in overdentures is surgeons don't realize the restorative space that you need for these restorations. They extract the teeth, they don't do adequate alveoloplasty, and now these implants are too high. And that's why with our removable cases, we see teeth popping out, or we see cracks in the denture, or the denture split, is because the implants were not placed deep enough in the bone. So when you have a case like this, an existing snap-on type of a case, sometimes an all-on-X isn't going to work because there's not enough restorative space. LOCATOR Fixed needs less restorative space, so this makes this kind of an attractive option for those kinds of cases. Also, in terms of the cost, and some of the cases I'm going to show, as a prosthodontist, sometimes we do crazy things and we go a little bit, get a little bit too detailed and try things that maybe somebody else wouldn't try. So some of the cases might seem a little more complicated, but in general, the cost for doing a locator fixed is going to be less, and so you can create a price point for your patients that's a little bit less than your typical all-on-X case that maybe makes the difference for the patient accepting a fixed case and paying a little bit less as compared to having a removable snap-on type of case. And so when you're thinking about how you present to patients the different types of options, prior to locator fixed, we went from a denture to a 2-implant snap-on to a 4-implant snap-on to a screw-retained type of a fixed prosthesis. And many times there was a big difference between like the 4-implant snap-on and the fixed. So locator fixed positions itself kind of in between there because, believe it or not, there are patients where 3 or 4 or like for a double $3,000 to $6,000 could make a difference in allowing them to accept that treatment as compared to the cost of a full arch restoration. And in your folders, you'll find the form that I give to all my patients when we decide that their dentition is hopeless or they're already edentulous, that goes over all of the different options for the upper and for the lower. And it shows what my price points are. Now, price is going to change depending on the materials you're going to use, where you live, what your laboratory costs are. And so I wouldn't take my price and say this is what I'm going to do, but at least it gives you an idea of what I do for my patients. And so there's the new option that I've added to my price list for locator fixed.